CCP presentation by Christina Tran. My patient is a 29-year-old female Hispanic. She is single and currently a student. She presented for adult prophylaxis and fluoride varnish and has no chief concern. Her last physical examination was last July and everything was in normal limits. She has no past drug or tobacco use and no known family history of medical conditions. Her general health is overall good. She has allergies to latex pets and seasonal allergies. She rarely drinks, only once a week at most. Her baseline vitals were within normal limits and her BMI was also within normal range. She takes multivitamins daily for vitamin supplements, birth control daily as a contraceptive, and cetirizine whenever she needs for her seasonal allergies. It is noted that when prescribing antibiotics, patient must be warned to use additional methods of birth control if on oral contraceptives. In addition, cetirizine causes xerostomia. I classified her as ASA2 due to her allergies. Her last dental visit was in 2019 for adult prophylaxis and x-rays. She routinely has her dental appointments every 6 months. She has no history of periodontal surgery or SRP. Her oral hygiene is considered fair. She brushes twice a day and uses floss picks occasionally. She brushes with a soft bristle toothbrush with fluoridated toothpaste and drinks fluoridated water. She presents with posterior staining on the lingual aspects due to coffee. She does not experience any pain or discomfort. Her initial plaque-free index was 38%. She has 1 mm recession on her mandibular posterior buccals and anterior lingual surfaces. She has amalgam restorations on number 3, 13, 14, 15, 18, 17, 30, and 31, and a Fuji resting on number 2. There is no tooth mobility, and her unattached gingiva was generalized rolled borders, and her attached gingiva was generalized pink, firm, and stippled. Her probing depths were generalized 2 to 3 mm pockets with localized 4 to 5 mm pockets on the posterior teeth. She had BOP on number 9, 14, and 29. Her ENI findings included maximum opening of 45 mm, overjet of 4 mm, overbite of 6 mm, class 1 for all of her angles classification. She has the cusp of carabelli on both sides, and she has deviation on the left side upon opening and closing, does not experiencing any pain, and this is due to clenching. Her bone loss was generalized horizontal with localized vertical in between number 29 and 30, generalized radiographic bone levels of 15% with localized 15 to 30%. Her crown to root ratio was generalized 1 to 2. Her PDL was widening on the posterior teeth, and her lamina dura was localized thickening on the mandibular left posterior teeth. According to the 1999 AAP, she has generalized slight chronic periodontitis with localized moderate chronic periodontitis. In the 2017 AAP, she has generalized stage 1 with localized stage 2 on number 4, 18, 19, 30, and 31 with grade B. She has generalized max probing depths of 4 mm. She has localized probing depths of 5 mm and interdental cowl of 3 to 4 mm. Her radiographic bone level is generally at coronal third, but making way to 33%. She has generalized horizontal bone loss and no tooth loss due to periodontitis. Her present oral hygiene status is fair. She brushes twice a day and uses a floss pick occasionally. She uses a manual soft bristle toothbrush. She drinks fluoridated water and uses fluoridated toothpaste. She presents with posterior staining on lingual aspects due to coffee consumption. She has no present pain or discomfort at the time of appointment. She shows interest in engagement of oral care during OHI. Her caries risk is high due to her current amalgam restorations and hyposalivary medication. Her prognosis is moderate. She has no other dental condition other than amalgam restorations. She has good dietary habits and environmental factors. She currently has adequate saliva flow and drinks fluoridated water and brushes with fluoridated toothpaste. Her OHI included flossing technique with C-shape up and down motion between the tooth and gingiva, suggested expanding floss instead of floss pick at least once a day, recommend alcohol-free fluoridated mouth rinse daily. Her oral health aids included non-alcoholic fluoridated mouth rinse, xylitol gum mints for anti-cavities, baking soda toothpaste with fluoride to prevent any dry mouth during time of her medication, an electric soft bristle toothbrush to prevent further recession. Her nutrition counseling included continued to limit snacking between meals, continuing to eat a healthy diet. Her carbohydrates and fats were lacking in a diet, so I recommended consuming complex carbohydrates and fats to maintain a healthy lifestyle. Overall, there was a low exposure to caries from a nutritional standpoint. No smoking cessation was needed since she does not smoke. There was a total of 4 appointments. On the first appointment, we did patient screening, consent, established treatment plan, referred to the DDS for her night guard, and provided her diet journal. On the second appointment, we did her plaque-free index, intraoral photos, obtained her diet journal, and discussed OHI in Canberra. On the third appointment, we did the full mouth hand scaled adult prophylaxis and discussed OHI. On her peri-reeval, we did her plaque index, intraoral photos, discussed OHI once again. I polished and applied fluoride, and I recommended her a 6-month adult pro-free recall. The prognosis of the patient's overall health was good. The patient has adequate periodontal support. She showed interest and compliance on oral health, and oral health is maintainable. Her oral health outcome goals were to decrease pocket depths and BOP and increase plaque-free index. In addition, we were hoping to reduce her gingival inflammation. At her periodontal re-evaluation, we saw an improvement on her probing depths and a decrease on BOP. Here is a comparison of her initial and current periodontal chart. We also saw an overall decrease of gingival inflammation. Her plaque-free index was 87.5% at her periodontal re-evaluation. This was a significant improvement from her initial plaque-free index, which was 38%. In conclusion, there was evidence of improvement on oral health, and she maintained oral home care. It's always important to find adequate research to support OHI for the patient. The articles that I chose for this patient involve correlation of stress and oral health, the importance of fluoride, and the association of flossing and periodontitis. Since she is a full-time student during a pandemic, her stress levels are extremely high. Finding research between stress and oral health validated my reasoning for her to maintain oral health by flossing daily and continue to use fluoride. In conclusion, I had a good and educational experience working with a real patient. I learned how to adapt to our new clinical setting due to COVID-19. I also improved on my communication skills and patient care. It was exciting for me to see firsthand the progress of a patient who truly wants to improve their oral health.